Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. And that is on a very important topic, that is managing the multi-drugs resistant threat before it's become unmanageable on the occasion of World Pneumonia Day. As we know that this topic is very much important, so we need someone who is expert. And this discussion is a panel discussion, and discussion is much needed as it is a very important topic, as I said. So for this, I would like to invite the host speaker for this webinar, none other than Dr. Vijay Varat sir. And let me share some of the achievement of sir. Sir is a consultant allergist, pediatric pulmonologist, clinical immunologist, and consultant at Sai Allergy Asthma Eye Hospital, Shaidri Hospital, Imamdar Multi-Speciality Hospital, Pune. And without any further delay, I would like to hand over this webinar to Sir. Sir, over to you. Sir, the stage is yours. You can proceed from here.
Yeah, good evening, everyone. And on the World Pneumonia Day, we are having a discussion on the pneumonias. Because as I remember, when I was doing my post graduation in Grant Medical College Hospital, we used to find a lot of patients with the pneumonias. The wards used to be full. It was like a number one uh, death causing disease, and still under five mortality. It's one of the very important death causing disease, as well as in adults also. In India, we don't have exact data, but around whatever the deaths happen, it's still on a higher side. And as compared to the worldwide deaths happening with the pneumonias, 20 to 30% adult pneumonia deaths happen in India. And considering the COPD as an allergist and clinical immunologist, and Dr. Harsha also is there here, we'll agree that the COPD and all those cases are increased. It's the second death causing disease in India. And amongst that, again, the pneumonia is one of the predominant one. So today we all will be discussing over here on the pneumonia, and I will welcome my friends and panelists over here. Dr. Harsha Jain, she's a adult pulmonologist, and she's practicing in Sahyadri Hospital, and she's practicing all types of like even interventional pulmonology to um, bronchoscopy, everything. And she's looking after the critical cases in Sahyadri Hospital ICU also. Another my friend, Dr. Pankaj is there, and Dr. Pankaj Vaidya is a MBBS MD Pediatrics and DM in Pediatric Pulmonology. Very few people are in Pediatric Pulmonology DM, and he is MRC PCH, RCPCH Fellowship, FIP, NRC, and Diploma, ERS Diploma in Pediatric Respiratory Medicine. He is the Professor Pediatric Pulmonology Unit, Department of Pediatric Medicine, Advanced Pediatric Center, Postgraduate Institute of Medical, PGIMER, basically Chandigarh. So I welcome both of you today for the discussion.
Thank you, sir.
So, like, we'll start with, as I mentioned, like, still in children, pneumonia is a number one death causing disease. So, Dr. Pankaj, like, what are you looking last 10 years or 20 years back, and how are the incidences now? See.
About the etiology, sir?
No, I mean pneumonia deaths. Like, I'm asking, like,
Pneumonia
many,
deaths. Okay,
yes,
okay.
deaths, yeah. I mean, you're seeing so many critical cases to you. They must be coming to for investigation. Yeah.
Yes, sir. So, very relevant question, because even now, pneumonia in children remains the commonest cause of under 5 mortality, ranging up to say 50 to 60% as per WHO statistics, and also the literature which is coming from our country. So to be very specific, like sir, you asked what I am seeing in my setting. So where I work is a referral center. It's the apex center of the country. So other than community acquired pneumonias and the complicated pneumonias, we have more referrals. We have more sicker patients, ones who are being referred to us from different medical colleges or from uh, settings wherein there is these children are not getting managed appropriately and there is a need for a referral. Such children primarily come to our center. So if you are talking about the statistics, so like the WHO shows, and there is a recent PERCH study from our center only. It's the largest in the developing world. So that also has shown similar uh, mortality statistics. Uh, but the setting wherein I work is a totally different setting. But maybe today we are here to discuss in general about pneumonias in children.
Yes. So, like, continue with that, are we witnessing a shift in the etiological spectrum of all these pediatric pneumonias due to the rising antimicrobial resistance?
So, so there is the common organisms remain the same, but truly speaking, now there is a shift towards viral etiologies. So
Mhm.
maybe there is no evidence to say whether these etiologies were always there, and it so has happened that now we are equipped to pick these up. And now, as the viral tests and viral markers are available, and we have started doing it, we have started considering these as one of the etiologies. Therefore, we are able to detect. So, like I told, in the largest study in children, uh, which is called the PERCH study, uh, the commonest etiology was found to be viral, and similarly bacterial, and other etiologies which remain indeterminate. So it was like a approximately one third, one third, one third scenario. But then, because this PERCH study had some limitations because it was done in different settings, so the study which I have earlier also mentioned, the CAPE study, Community Acquired Pneumonia Etiology Survey, it is the largest in the developing world, and it was primarily done at our center in APC PGIM at Chandigarh, wherein again uh, the indeterminate etiologies remain as the maximum, maybe something like roughly 40 to 50%. Whereas, followed by that, viral and bacterial 12% and 18% remain almost like similar. So viral etiologies have come up in a big way. Maybe we are detecting now, that is why. Otherwise, the organisms remain the same in children, which are like H. influenzae, Streptococcus pneumoniae, and Staphylococcus, followed by gram negatives. So I hope that answers my question, sir.
Thank you. Thanks for that. So, Dr.
Yes.
Harsha, like, looking at this all, like we discussed about viral bacterial. So, what do you feel about the bacterial pneumonias, like specifically working in Sayadri ICU and these multi-drug or the extended drug-resistant organisms currently?
Yes, so when it comes to community acquired pneumonia, still the organism remains the same. But what we see recently is initially community acquired pneumonia because of MRSA was were very less. But now we see lot of community acquired pneumonia with MRSA also. And next coming to MDR and XDR pathogens, yes, there is significant rise in MDR and XDR pathogens. And also we see lot of post-viral bacterial pneumonias, and those being very severe and multi-drug resistant, especially after COVID and after influenza. We have seen that there is a significant rise in post-viral bacterial pneumonias. So we commonly come across these all pathogens in our day-to-day practice. So most commonly MDR XDR we come across recently is most of Pseudomonas acinetto, Burkholderia. There has been significant rise in all these organisms when it comes to hospital acquired or ventilator associated pneumonias. Otherwise, coming to community acquired pneumonia, the pathogen still remains the same, but a lot of viral infections also have been increased. There's increase in the viral infection. So these are the common organisms we are coming across.
Yeah, absolutely. I agree with you. Even last year only, I was conducting one of the fluticasone clinical trial, and day four only, the woman, 37 years old, she got some influenza pneumonia. She was admitted in the ICU, and then she developed a pneumococcal, and then secondary infections, as you said, Acinetobacter, and she
Yes.
was there for 3.5 months in the hospital with empyema surgery requiring then thoracoscopy and all. So these cases are definitely increasing. So, like,
Sorry to
how?
interrupt. We have seen, sorry to interrupt, and we have seen a lot of influenza-associated aspergillosis recently. So what we
Oh,
call it as IAA. So we are seeing a lot of cases in adult.
yes. So,
Yes.
I mean, the scenario had changed post-COVID. We are seeing all these different type of combinations and secondary infections, definitely. So, like, as an intervention in pulmonology also, how will you have cultures or specifically, like previously we used to have a traditional sputum cultures and all, and empirical therapy used to be given. Now, so how will you uh, manage these patients?
Sir, now also the thing remains the same. Even in community-acquired pneumonia, we don't go for a bronchoscopy initially, sir. It is just sputum culture which we go for. Or even now we have PCR available, multiplex PCR, even we go for that. When it comes to ventilator associated pneumonia or hospital acquired pneumonia, that also remains the same. We still go for a culture only, endotracheal culture sensitive only we go for. But only there are few indication. In if you go according to IPSA or ERS guidelines, also there are only few selected group of patient in whom we go for a bronchoscopy in them. So the thing is, we only those patients who are immunocompromised, those who are not responding even after 48 to 72 hours of empirical antibiotic, and those patients, you find that even culture being negative, you see the clinical deterioration in them, but you're still suspecting that there is a pneumonia, and still after starting empirical therapy also there is no clinical response. In only in these selected cases we go for a specific sampling from the targeted area, and we send that for culture and multiplex PCR. So the only advantage I find is there's a difference in the yield of both. So when you find see the yield in ET culture or a sputum culture sensitivity, so the yield is around 30 to 40%, but it is increased to 60 to 80% when you do a bronchoscopy from a targeted site. The one more disadvantage being with the sputum culture is there is a mixed flora. So even the normal flora has been picked up. So it becomes very difficult to find out whether it is a colonization or it is actually an infection. So in such cases, bronchoscopy does play a role. And also in case of, we use bronchoscopy more so in non-resolving pneumonia cases. So those patients in whom we see there is no clinical improvement or radiological improvement, to find an alternative cause or find out the MDR pathogen, we go for a bronchoscopy. Otherwise, we don't opt for a bronchoscopy over empirical therapy.
Yes. So, Dr. Pankaj, in pediatric also, how we manage? Yeah. Dr.
So,
Pankaj,
yes, sir. Sorry,
pediatric
anything
yeah.
specifically? Uh, can you please
Specifically, how suppose
repeat?
sometimes, as Dr. Harsha said, in some difficult cases where the antibiotics empirically are not working, and if you want to go for a fourth generation one, so like interventional, like bronchoscopy and all, any specific cases you have got that to have the culture or to identify the this one microbiology, basically.
Yes, sir. Yes, sir. So, sir, in our setting, we have a strong microbiological setup, wherein not only bacteriology but virology, parasites, and otherwise mycology also. So, the cases which are admitted to our hospital, they undergo thorough workup, including respiratory secretions, cultures, as well as blood cultures, which provide a good yield because the labs are standardized. And the the point which you asked, the specific cases, so for bronchoscopy and all, we don't have any prophylactic antibiotic policy, and there is no need. There is no such guideline, and these children fare well even without antibiotics. They don't need any such. But in once in a while cases, like in foreign body aspirations and all, wherein we find there is mucus plugging and there is secondary bacterial infection, so then we treat them with specific antibiotic. To start with, we go with broad spectrum, which probably that is what you mean by empiric antibiotic, and then we tailor make it according to the culture sensitivity reports of say sputum or respiratory secretion and blood cultures.
So for the pediatricians, like how will you guide like how to differentiate bacterial, viral, or a typical pneumonias?
Yes, sir, that's a pertinent question and takes back to our MD training. But I agree that that is the most challenging thing uh, uh, our resident has to do when he comes in first contact with a patient.
Yes.
But somehow I feel that there is a lot of exaggeration about confusion in the three entities. So, wherein the pneumonia is not so severe, so so we are not in a hurry to rush with uh, starting antibiotics or labeling the child as this or that. And in pediatric patients, see the situation evolves. So the key lies in observing these patients to monitor to keep them in follow. But of course, like you said, if you specifically ask me, how do we differentiate? So in viral, as it is conventionally uh, said, and we have been trained like that, that when the symptoms are a lot, but the signs are not very much. So that is something which indicates towards a viral etiology. Whereas bacterial, when the child is toxic and you specific, there are specific findings. Like in above 5 years, they are able to localize to one lobe. So we can find a bronchopneumonia, which will, wherein we will find localized crepitations, bronchial breath sounds. Whereas in viral, it would be a diffuse kind of picture. And of course, crepitations can come up along with wheezing, both in viral and bacterial. But generally, when in acute situation it happens, it would be more, the diagnosis would more incline towards viral etiology. There are situations wherein children with viral pneumonias may develop secondary bacterial, but these are kind of quite rare situations. And as such, this concern lies that the child should not progress from uh, not a severe pneumonia to a severe pneumonia. But there is no role of any prophylactic antibiotic. We just have to clinically monitor the child and observe. Entity of atypical pneumonia is also one which we sometimes observe. Generally, these children are a bit older, maybe adolescent, which doesn't mean that younger children would not have atypical, but commonly these are like in adolescent age group. And the the children are become quite sick quite quickly. And there are some investigations which we may want to do, like a chest x-ray or uh, blood counts or crp procal in children who have severe pneumonias. So, and of course blood cultures and respiratory secretions cultures. So in chest x-rays, wherever we see a defined lobar consolidation, it indicates a bacterial, more sort of, and wherein there is peribronchial thickening and a diffuse kind of picture, it indicates a viral etiology. Although the viral picture takes time on the chest X-ray to evolve, and in atypical, we would more sort of find an interstitial picture. So these are the children who would respond better to macrolides. So that is how I look towards it, sir. If
Yeah,
that is,
you beautifully really gave all the things. The common pediatrician also can understand that. And Dr. Harsha, like in adults also, uh, is there any specific one like how the practitioners should differentiate?
Sir, in adult also it applies the same, sir. It is same as the pediatrics actually.
Acha.
Yes, sir, it is same, sir. So if we see a lot of radiological feature and patient being quite okay, we usually suspect atypical pathogens more.
Okay.
So the same thing applies even in the adult age group, sir.
So thank you. So are we over relying on imaging while under recruitizing the diagnostic bronchoscopy in critically ill patients with non-resolving pneumonia?
So the question is to me, sir.
Yeah, yeah, for you only. Are we
Yes,
over
because
relying?
So it is very difficult in case, especially in case of non-resolving pneumonia, we have a different, we have a differential diagnosis. So it can be a atypical infection, it can be a post-obstructive pneumonitis, and in adults, sometimes this non-resolving pneumonia can just be a malignancy. So just looking at the imaging, these things cannot be differentiated. And in such cases, I think bronchoscopy significantly plays a role, at least to find the causes for a non-resolving pneumonia. So I think just imaging would not suffice in case of non-resolving pneumonia. So the additional modalities are required to find out the cause for non-resolving pneumonia.
Yeah, absolutely. I think people don't understand that. Sometimes it's very difficult to convince the patient also to have an
Yes.
invasive. The always CT scan will pick up all everything, and the doctor should differentiate on that, and he should treat on that. That's really.
So
And
we miss a
again,
lot of pathogen actually in that. More, lot of causes for non-resolving pneumonia is missed if at all we just go CT or X-ray wise and empirically treat them.
that's true.
And that too
So again,
in India, being in India, I think tuberculosis would be the main one of the main pathogen which is responsible for non-resolving pneumonia. So we need additional modalities to find out the cause for non-resolving pneumonia.
yes, thank you. So again, the next question to you only. Can interventional procedures like percutaneous catheter drainage or endobronchial valve replacement aid in managing the post-infective complications, specifically
Yes,
abscess and meningitis?
especially in case of necrotizing pneumonia, we do come across, especially in staff-related necrotizing pneumonia in ICUs, we have come across that patient have bronchopleural fistula associated with this necrotizing, severe necrotizing pneumonia. So the main problem, what happens in this case is we see is because of the persistent air leak, because of the bronchopleural fistula, and this the leak is quite significant. So in such patient, ventilating this patient becomes very difficult because there is a lot of leak which is going on in this intubated patient because of the bronchopleural fistula. So in this case, in such scenarios, what we do is we do a bronchoscopy. We do a bronchoscopy and find out the segment from where the leak is going on. So we use a Fogarty balloon and we go on blocking each segments of lung from where the BPF is. So if we are able to localize from which segment a significant leak is from the ICD tube or a bag, if we see, and if I block that segment and if I see there is a significant more than 50% reduction in the leak, so that is a segment from which the most of the leak is happening. So in such cases, we use spigots, vertebral spigots we use, we even use glues, or even we use a autologous blood patch to block this leak so that we are able to ventilate patient properly. So we have seen patient wherein sir, we have tried double human intubation also in them so that we can give a rest to one lung and manage with one lung. But what happens is most of the time the main problem in such patient is hypercapnia. So in such case, we use these bronchoscopic modalities to block the BPF. But when coming to the lung abscess per se, we usually do not perform percutaneous drainage, sir, because the main disadvantage of this is it is associated with higher risk of BPF, bronchopleural fistula, as we are putting a catheter into the lung per se. So if feasible, we would recommend surgery. If patient is not responding with the lung abscess, we usually prefer surgical resection than the percutaneous drainage. But in non-surgical patient who are not responding, in such selected patient, we do try it to reduce the burden of the organism.
That's good. When selectively we can manage that.
Yes.
So, yeah, Dr. Pankaj, like I still remember there was a case 3 years back, 6.5 years, girl from Australia, and she was a known asthmatics, and she was admitted there 3 months back with a severe episode of pain, and she was not given a single antibiotic. Also, she was in a very severe asthma, and managed all that. But when this girl was to here in one of the corporate hospital, and same episode happened, so she was given 2 3 antibiotics, everything, and then the relative, one of them, had been one of my patient's relative. So he called me, he showed the papers and all. So basically here it was not investigated, only CBC was done, and all the 3 antibiotics were given. So like our scenario, so these empirical antibiotic guidelines still are effective for community acquired pneumonia, or do they need a urgent revision basically?
Sir, the one line answer to your question is there is nothing called prophylactic antibiotics
Yes.
in routine pneumonias. So these are special cases like immunocompromised children, or they are on long-term steroid therapy, or they are like uh, viral these retropositive HIV children. So other than these, I don't see any children in whom there is a role of prophylactic antibiotic. Then, like you said, empiric antibiotic therapy is a common term, but somehow I don't see that word in the guidelines that we practice with. So these are primarily the uh, IMNCI guidelines, the pneumonia guidelines that we have in our country. And to my mind, they are much evidence based and robust guidelines. Of course, they have the riders that uh, many things are directed towards the peripheral health workers in the community setting, wherein how they are able to take decision about whether to give antibiotic to a child or not. When they classify the child into no pneumonia, pneumonia, and severe pneumonia for children, I'm saying the so. But when the child comes to a doctor, uh, and especially to a pediatrician, then I think it is our duty to make full use of our clinical acumen and not just to give antibiotics empirically. Giving antibiotics empirically means that we are not confident about our diagnosis, and there might be situation wherein wherein the thing is life threatening, and as a desperate measure, as a last resort, wherein we don't have anything to fall back on, and there is a suspicion of uh, maybe infection, a pneumonia. So in those situations, I agree that empiric antibiotics would have some role. But like the example which you have given is a very good example, that in private settings maybe our colleagues are forced to do so because they don't want to lose the patient, neither uh, the life of the patient, nor from their private practice. So that is why they leave no stone unturned, and to give all the cocktail and something might work. But that is not the right thing to do. Otherwise, why these guidelines have been framed, and they work well. It is much evidence based. So I don't see any reason to give antibiotics to a child who comes with an exacerbation of asthma or acute severe asthma. Even there is no indication of doing any investigations in such a child. The only thing I think one would need to see uh, uh, is whether the AEC elevated or total IG. That also in a situation wherein you think that the asthma has something else associated, like a ABPA or something, then only these investigations are indicated. But giving antimicrobials empirically would not be the right thing to do. That is
I
all.
agree with you.
Yeah,
I mean, early
yeah,
aggressive therapy rather than that. We should be having a rational antibiotic use so that the
right.
next, because to form one antibiotic, it takes so many decades to have a newer generation. Until the antibiotic comes, already the organisms have become resistant to that. Like I remember when vancomycin was just introduced into the market, that time already many of the organisms were resistant to that. So to have some antibiotic, it always takes a. So are any nosocomial and ventilator associated pneumonia in pediatric ICUs becoming the next major source of multi-drug resistant infections?
So I would say not a major source, but yes, the PICO situation, the pediatric ICU situation, or ventilator associated pneumonia is a very specific entity, wherein if the child comes with, say, an organism which is not resistant to antibiotics, may turn to be having a resistant organism, but that is not always the situation. And like madam also told, in adults also, when they do some interventions, there is high likelihood that organisms will harbor there. And because there is a facultative multiplication of these organisms, so there is a high probability of getting it as a resistant organism. But uh, resistance coming from the community, I would not buy that idea. So that prevalence is like very less.
Yes.
So yeah, so but in of course in ICU settings we have to be vigilant. So these are not the routine settings. We are not talking about pneumonia or very severe pneumonia. These are children who are like, this is a very severe pneumonia which has gone into failure. So they are into respiratory failure. That is why they are being ventilated. And there are a host of factors which are uh, playing their part alongside the pneumonia, so which have to be looked into. And supportive care appropriately has to be given. And antibiotic policy, to my mind, has to be guided by the local antibiotic resistance pattern which that particular ICU or that setting has, or that hospital has. Like we don't deal with the ICU in PGI. So there is a separate team we have which has its own ICUs, and there are three separate kind of critical care setups they run: the pediatric emergency, the high dependency unit, and also the pediatric ICU. So wherein they have their own policy to make an audit of whatever organisms they have got over the last 1 year, and also their resistance pattern. So the antibiotic policy this team uses is according to that very kind of pattern they have in their ICU, which keeps on changing every year. So that is how I would suggest that it should go about, and one should try to generate evidence of the organism profile of their own ICU or hospital. And similarly, uh, better to emphasize that antibiotic stewardship program is something which should be ongoing all the time in such settings, in ICU, in ICUs especially, because uh, prevention is the best method to kind of avoid these situations. So which is like having the BAP prophylaxis bundle. So we call it a bundle. Uh, so every ICU should have its education program to prevent these ventilator associated pneumonias, which comprises of simple measures like avoiding long term ventilations, and in feasible situations prone ventilation, then using non invasive ventilation, using uncuffed endotracheal tubes in children. So hand hygiene, and early riles tube feeding like in children we use. So that is what is from my side, sir. If you,
Yeah, thank you. I mean, absolutely right. I agree with you. As an institutions, it's completely different because we always follow that there are seniors, then there are people, they are going to ask you why you did this, why you gave this. But in private practice, as you rightly said, to have a adherence to the patient, and the patient should have a immediate relief. So many things are used. So Dr. Harsha, like you are practicing in Sayadri, like what do you feel like as a challenge when the patient suppose is admitted in a secondary care level and then he is referred to you know the drug resistant pneumonias and all. So the difficulties will be there to investigate and all because already he has been given many antibiotics. So what will you suggest like to the private practitioners, primary care physicians, what type of guidelines should we form stewardship program as Dr. Pankaj said. So in a
So
private also like Indian Medical Association as well as the physicians associations, so such type of antibiotic guideline should be there. So what will you say on that?
So usually what we follow is based, as sir said, antibiotics stewardship. It is difficult in the private setting actually, but still we follow that. We find out as we have ID people with us, infectious disease specialist with us. So usually they let us know which is the most common pathogen we come across in our ICU. So, whichever MDR pathogen is very common in our ICU, we start antibiotics based upon that whenever we have a suspicion of ventilator associated or hospital acquired pneumonia. But when it becomes very difficult when patient has been referred from the different setting after being giving multiple antibiotics and after being treated with enormous cocktail of antibiotics, so it becomes very difficult for us to identify exact organism and also treat this patient accordingly. So it becomes very difficult initially to what antibiotic to be started because they would have been given lot of antibiotics already. So what we do is we go for a primary investigation at our setting. First, we try to find out that, and also if at all culture and all has been sent at their setting. So we try to trace that, and we go and treat accordingly. But sometimes, sir, what we have seen is whatever basic antibiotics has been started for the patient, and same antibiotic also works now. But only thing is we need to find out that what other associated infections are a possibility. So what we try to do is we try to send a repeat cultures in them. Until then, we wait actually. If patient is still in a better condition, hemodynamically stable, we still wait for the cultures to come. If at all we see any deterioration, we try to find out what is the possible cause that patient has been deteriorated. Sir, sometimes what we have seen is a patient with ARDS pneumonia who has been treated outside. There's a lot of volute trauma. Sometimes we have seen a pneumothorax patient coming with, and they fail to identify pneumothorax in patients who are intubated because in them we see just deep sulcus sign. So in such patient, whenever they see a deterioration, they just upgrade the antibiotics without without actually finding out the cause why patient deteriorated. So we have come across many cases wherein patient has actually pneumothorax, but he's been given multiple antibiotics because patient suddenly had increase in oxygen requirement or inotropic support. So we don't jump into initially just switching over to antibiotic. We try to find out the cause why patient has been deteriorated, because sometimes we see that there's a lot of fluid that is being given. Instead of giving a restricted fluids in patients with ERDS, they give a lot of fluid to them, and what we have seen is it is rather a fluid overload which a patient comes with, and that has led to the deterioration rather than the newer infection. So whenever a case is referred, we usually don't jump into starting MDR related or XDR related, most common pathogen related or treatment or upgradation of antibiotic. We first try to find out the cause and then accordingly we change our treatments.
Thank you. I mean, absolutely right. Even the primary physicians or pediatricians, they should always involve the pediatric pulmonologist or chest physicians, interventional pulmonologist, because so that we can come to the real cause of the thing and then we can treat it. Definitely. Dr. Pankaj, like, can host
Sir,
diabetic therapy?
if you permit, I would like to add a point.
Please.
So, sir, in long run, like you said, in private practice and wherein pediatricians are doing private practice, it is not feasible to do maybe antibiotic stewardship and to send cultures and to keep an audit. But if there are people who are listening to our talk and who are into practice, I would like to emphasize that, in fact, in long term, this would be much more helpful for you. In fact, it will kind of even your practice will uh, expand further if you follow these kind of measures, which will help your patient as well as uh, it would be in long run more productive, and
Yes,
the
that's true.
outcomes would be better.
Yeah, that's true. Absolutely. Thank you for that. So, Dr. Pankaj, again, can host-directed therapies or immunomodulators play a role in reducing antibiotic dependence in future pediatric pneumonia management?
Yes, sir. But there is nothing very specific that has come up as of now. And these are therapies which are like futuristic, but they are not replacement for antibiotics wherein these are indicated. Uh, like in a child with bacterial pneumonia, you will have to give antibiotics, or with viral or atypical or any other form of pneumonia, you will have to give the supportive care. Ventilator associated or hospital acquired, you will have to give the supportive care. But the immunomodulator therapy looks to be very kind of lucrative
Lucrative.
option. Yeah,
Definitely.
and people would want to give so many things, like many vitamins come up intermittently, many other measures come up, many pharma brands will come up with some drug, and they would say that if this is complemented along with antibiotic, it will help to reduce. But there is no clear cut evidence of any such therapy, at least as of now in children, as far as I know. Yeah,
Yeah.
there are some promising things which may come up in future, but these have to be very carefully assessed, and then uh, trials have to be done in children as well before these are kind of used in daily routine practice.
Yes.
That is what I feel. So
Yeah. So, how do nutritional status, comorbidities, air pollution, they influence the risk of and outcomes of pneumonias in the children?
that's a very pertinent question, sir. And nutritional status, especially for us pediatricians, it is one of the major thing that we look into, because it's like very easy to see that, and evidence based, that children who are well nourished would recover much faster. Rather, when I counsel, I tell the parents that uh, your child would not have had this pneumonia if he was well nourished. So we will treat this episode of pneumonia, but you work on his nutrition so that he may not have such an episode in the future. So this nourishment also includes the protein content within the body, which actually is determines how well these children would fare, along with other micronutrients. And of course, like we know, malnutrition in different forms and failure to thrive in our part of the world is very common. And even in very affluent societies and affluent families, sometimes the parents are not able to pick up that their children are malnourished. So this malnutrition can both be a undernutrition and a overnutrition. So when the children are like failing to thrive or have protein energy malnutrition, that is one end of the spectrum. And on the other side, obesity is also a type of malnutrition, wherein these children uh, have developed excess of adipose tissue, and their response to normal secretions, normal hormonal insulin secretions in the body is abnormal. So in both the situations, these children may tend to have a pneumonia which is much more severe, would take a longer time to recover, and may lead to sequelae. Then about comorbidities, as you asked, so COVID was the best situation wherein we found that with comorbidities, the mortality rate is very high, and these children would develop pneumonias very easily. And it applies to all kinds of comorbidities, especially when the children are on any immunosuppressive therapy, especially steroids. So that is the thing. And of course, pollution is one of the factors which is coming up in a big way. WHO has now started recognizing it in the relation to pneumonias in children. And uh, of course, indoor pollution in our country is very common because chulha use is still very common. Parents smoke, the father especially, and also because the standard of living are not so high in majority of our population, so they are much exposed to uh, pollution in the fields or by roadside or in construction site, which predisposes them to different forms of pneumonia, and again the severity can be high. So in not so well-to-do families, all the three entities which you just now narrated would be playing a role in a child's pneumonia being more severe, taking more time to recover, and maybe leaving some sequelae on recovery. So that is what I would like to say on this issue.
Yeah, yeah, absolutely. Like post Diwali, I'm seeing a lot of cases of pneumonia. Like my patients, because I am an allergist and clinical immunologist, even like 16-year-old child had been there today only. And post Diwali, after 3 days, he had some infection viral, and then it led to secondary infection, and he had a pneumonia. So again, one 8-year-old child from a rural area had been there. 3 episodes of pneumonia last 6 months. So even in the rural areas, because of the pesticide use and all, the pollen's potency has increased, and so many diesel particles in the farming and all they are using. So many equipments they are using a diesels and all. So they are also adding on that. And then, as you rightly said, besides the chula and all, even the deodorants, perfumes, toilet cleaners, they are also one of the big indoor pollutants. And then the pets and all at a house, their danders, their furs, they are causing us a lot of dust mites contamination, and as pigeon feather droppings. So these type of things are again increasing, and like all the cities, like specifically in Pune, it's a number one in construction dust now. And so the dust can go up to 64 kilometers vertically and 80 kilometers horizontally. So imagine how they are having the impacts to the community. Thank you for that. So Dr. Harsha, also like in adults, what will be these things like nutrition status, comorbidities, and obesity is a big problem in adults. Obstructive sleep apnea.
Yes, sir.
Yeah. So
So they have the same impact. So malnutrition, it increases both the mortality and morbidity, especially the morbidity is increased. And coming to the pollution, what we see is definitely there is an increase in possibility of allergic rhinitis has increased, allergic symptoms have increased, and the most important thing to respiratory physician is we see a lot of exacerbation of asthma and COPD because of this pollution. And because of the pollens, because of the allergen triggers, we see a lot of basically the underlying lung disease patient, we see worsening of these symptoms and exacerbation requiring admissions, requiring multiple admissions. So there's a worsening in this kind of patients we have seen because of this pollution. So otherwise malnutrition and obesity same as the pediatric age group, the same impact we see in adults also.
yeah, I still remember when I was in Sayadri ICU, and you were seeing that 23-year-old girl with a BiPAP and all, and she had a pneumonia. And last 6 months, she was admitted 3 times. So at such an early age, having a COPD, 23 years old, I can't imagine that. Do
No, so
you
the
remember that?
problem
Yeah.
the problem with that girl was she was a childhood asthmatic, and next is she was lost to treatment. And one more thing which was leading to recurrent asthma exacerbation was her OSA. She was 110 kg, sir, at the age of 23
Yeah,
years.
I saw her like that day. Yeah.
So yeah, and she was not compliant with the therapy. Even we had done a sleep study for her. We had started her on CPAP therapy also, but she was OHS. We had diagnosed her as, but she was not compliant to the treatment at all. So, so she was there, and just to tell you what happened with the patient, she was there till now, but recently we lost her, sir.
Oh.
She was admitted
So
for
this,
nearly 6 months because OSA was not getting under control. We had to tracheostomize her because, sir, every now and then CO2 retention. She used to go into hypoventilation because of her OHS component. So eventually, we ended up with tracheostomizing her. But then she could not make it because of multiple hospital-acquired infections and so many things happened later on.
yeah. So such a young adolescents and all, we are losing. Still, I remember my three of my patients in adolescents. We lost them because of such a severe asthma with comorbidities, obesity, then even COPD also. So the smaller airway diseases are increasing because of all these comorbidities. So the practicing doctors also should understand this. The changing scenario, we have to identify that. Again, immunodeficiency syndromes and all that is also one of the very big. I mean, it will take 1 hour for that. So today we'll not cover up those things, and those cases also the pneumonias are different abscesses and all. So how like as a pulmonologist, how we can strengthen the surveillance and reporting of these resistant respiratory pathogens at the regional level also.
It is very difficult at the regional levels because we need collective effort from everybody. The ICU specialist, it might be infectious disease specialist, and even by the respiratory physician, there should be a collective effort to change it. And also, we have to stop unnecessary antibiotics in people. Even if I see a minimum upper respiratory tract infection, we just load them with a lot of antibiotics. I think we should change that trend of giving multiple antibiotics or a cocktail antibiotics to the patients. And also we should try to utilize the modalities we have in case of if we find that patient is not responding to the particular line of treatment. We should, instead of starting just a empirical treatment, I think we should go to a proper diagnostic levels and find out the cause for particular illness rather than just starting patient on empirical treatment. Because I see a lot of cases in which it is just a pneumonia where patient is not responding to the basic antibiotics. A patient has been just started on empirical tubercular treatment. So I feel in such cases, instead of starting patient on empirical treatment, we should find out the cause for the pneumonia which was not resolving. Because we have seen one or two cases wherein we found a beetle nut. It was a post obstructive pneumonitis. So it was a foreign body which was causing non responsiveness. So I think in such cases, instead of empirically starting patient on ATT, we should take a help of respiratory physician or anybody who is specialized in that field, so that sir, we can avoid multiple antibiotics in them.
Thank you. So, as a pediatric pulmonologist and as an allergy clinical immunologist, we are using the vaccines in children regularly as a influenza, pneumococcal, and all. But recently, like when we attend the meetings and with this all pneumo 20 vaccines and all, so these vaccines also in adults. How do you recommend like which high risk patients they should be
So
vaccinated in adults?
any patient with a chronic lung disease, we usually advised annual influenza infection. We also give a pneumococcal vaccination in them. And in patient with COPD, we also recommend Shingrix herpes zoster vaccination in them, sir. So these are particular vaccination we recommend in all patients with chronic lung disease. So to prevent severity of pneumonia, we usually recommend these vaccinations in them.
Yeah. Thank you. And even like as I mentioned, as a clinical immunologist, we are recommending to the even chronic heart condition patients, then even obstructive sleep apnea patients, we are recommending because they are also prone for that.
Yes, sir.
Even
Any chronic lung, chronic heart, any immunocompromised patient, uh,
obesity.
yes, yes, patient who are on chemotherapy, any immunosuppressive drugs. In all these patients, we are recommending regular vaccinations.
Thank you. Thanks a lot. So already there are a lot to discuss on that, but the time limit is there. So thank you. I think Dr. Pankaj we lost his. I think he lost his internet connection. So thanks really, Dr. Ansha and
Thank
Dr.
you.
Pankaj, and
Thank
thanks
you. Thank you
to
so much for the opportunity, sir.
Dr. I mean IJCP. Of course, any questions are there from the audience? If anything, we can take it.
No, sir. Like you have covered all the points, I think, sir. And there is two feedback from Dr. Priyarshani, like very important topic discussed on important day, and wonderful discussion from Dr. Anshuman.
Okay, thank you. Thanks a lot. I mean,
Yes,
thanks
sir.
Thank you.
to you for really organizing each and every moment you organize any like weather change is there, pneumonia days and all. So, Dr. Pankaj, I mean, thank you for your really thoughts on that and for such a
Yes, sir.
good issue. Yeah, and still
Sir,
you
like
are.
good thanks to you all that you all doctors are available for having an informative initiative, sir. Without you, we are nothing, sir. Thank you so much for wonderful discussion on
If
this
there
topic.
are, if you allow me to give some last moment comment,
Yeah, yeah, please,
Yes,
please.
sure, sure.
Yeah,
yeah. So,
yes, sir.
uh, like we have this presentation, this panel discussion today on the event of the childhood on the pneumonia day, rather. So we are used to saying children, but it's a pneumonia day, World Pneumonia Day, and from my side, I think the awareness about pneumonia has to be increased amongst the practicing pediatricians and also the physicians. So for that, regular discussions are very important. The other thing is that we have to be more evidence based. Like based on just one or two clinical cases, we should not take empiric decisions. And there might be situations wherein cases might be difficult and you have to deal with on a case to case basis. But as far as possible, generally, we should follow the guidelines. Number three, I would like to say that antibiotic stewardship programs are like backbone in today's world to control this antimicrobial resistance. So we should have a clear-cut policy in our own hospitals and clinics. How are we going to adhere to? And more than losing the patient, uh, you should be worried about losing your credibility when you don't follow the guidelines, because we are entering into an era of information wherein on a click of a button the patient would have all the information, and it would not be long enough when the patient would come to know that uh, he or she was given antibiotics empirically, and especially in the case of children wherein parents uh, might be want to use the medical legal route. So we have to be careful about that.
That's true.
And especially about children, I would like to emphasize the long-term implications of giving antibiotics. So there is a normal microbiota of our own body, which is called the human microbiome. And each individual would have his or her own signature microbiome, which is influenced by various factors, including as little a factor as the mode of delivery, whether it was vaginal or cesarean, and also whether factors as little as how the exposure has been over the childhood, whether the child has been brought up in a field or in posh cities. So that also influences the microbiome of a child. And these children grow up to become adults, responsible citizens of the society. So when we give antibiotics to the children as pediatricians, it's a responsibility that we have to be careful that we don't disturb their normal microbiota, which is providing their defense system, their mechanism to evolve of their immune system. So these are kind of risky things, and a judicious use of antibiotic is the only solution to what I'm trying to say, because
Yes,
disturbing this microbiota is related not only to uh, diseases like mental diseases, but also to inflammatory bowel diseases and allergies. Dr. Vijay Varad is a specialist and he would vouch for what I'm saying.
yes,
So,
absolutely.
therefore, antibiotics are like a double-edged sword, and we have to, as clinicians, it's our responsibility to use it very wisely and judiciously, especially in children. The younger the child, the more cautious you have to be before using any kind of antibiotic.
That's true. That's true.
Over to you,
Thank you.
sir. Thank you for that opportunity and to allow
Summarizing,
me to call this.
and all the discussion happened very well. Definitely, in the next episode, we will have a more precise one. Again, different type of pneumonias and how we can interfere with that. Thank you. Thanks a lot.
And thank you so much, sir. And we would like to see you in future also with different topic. It was great honor to have you on our platform, sir. It was pleasure, and we would like to see you in future also. Take care, and I would like to thanks all the participants who have joined on this session and make this session informative one. Take care, everyone. Good night.
Good night.
Thank you. Thank you. Bye.